We're going to move on to 0530, California Health and Human Services Agency. We'll be hearing about the CalHERS Oversight, Office of Patient Advocate, and the high-cost drug proposal. Starting at page 13 in the agenda.
Hi,
Good morning.
Madam Chair, members of the committee. I'm Melody Hayes. I'm a Deputy Director at the Office of Systems Integration. And I have responses to the questions from the agenda, if you'd like me to go over the responses.
Please do.
Okay. The first is describing the governance structure of CalHERS and OSI's role in regards to CalHERS. The California Healthcare Eligibility, Enrollment, and Retention System, which is known as CalHERS, is one of the most complex IT systems in the country and has had monumental impact on the citizens of California, enabling them to enroll and receive affordable health care insurance through private insurance plans or Medi-Cal. Typically, new automation projects are supported by years of program and policy development and are usually in response to the need for improved business processes or outcomes. Instead, CalHERS went live in a much shorter time frame. As you are aware, we accomplished much over the past 18 months, but still have more to do, including refining the governance processes for the project. The primary mission of the Office of Systems Integration is to provide management and oversight of large-scale health and human services information technology projects in California. OSI has the project management oversight role for the CalHERS project. Accordingly, OSI formed a quality assurance team. OSI is working to develop and implement more robust governance processes on the project, as well as working with sponsors and county partners to ensure they are engaged in setting priorities. There are also a variety of external stakeholders that provide input to the sponsors on needed system changes that help to inform the priority setting process. OSI is responsible for engagement with sponsors to help ensure priorities are appropriately identified and communicated in a timely manner. Second question, provide a high-level OSI recommendations in regards to CalHERS governance. The initial focus of the quality assurance effort has been internal to the CalHERS project, which includes the two project sponsors, the Department of Healthcare Services and Covered California, as well as project stakeholders, the SAWS Consortia Systems, the County Welfare Directors Association, and the Department of Social Services. The quality assurance team identified governance objectives that are related to timely decision-making, involvement of sponsors and project partners in the decision-making, and clear responsibility and authority for decision-making. And we did send the detailed recommendations this morning. I apologize that we were late getting them to you, but you have them now. So. The third question is, what's our understanding of the criteria that the CalHERS project sponsors use in establishing the release schedule? The document that the CalHERS team refers to as the 24-month roadmap was developed as a coordination tool and will be updated and used over time. It brings the program priorities together with the technical capacity of the 5 production and including the leader replacement system, 6 systems that are part of the CalHERS universe. The sponsors and partners identified business goals as the guidepost for CalHERS changes. Those goals focus on the needs of consumers and the sponsors and partners and the system's technical infrastructure. The sponsors and partners identify their and their external stakeholders' programming priorities and bring them to the project change control process. There, the sponsors and partners work with OSI and the CalHERS team to incorporate the priorities into a release schedule. When creating the release schedule, the project considers the sponsors and partners' priorities and the technical constraints of the 6 affected systems.
Go on to, okay. You can answer all the questions and we'll open it up for additional questions.
Okay. And then the last question is, given OSI's vision as a trusted leader in the management delivery of projects, what do we think OSI's role is or should be in regard to ensuring that CalHERS project sponsors consider and evaluate external stakeholders' input regarding CalHERS changes and releases? So OSI has the responsibility for ensuring governance processes are followed and to assist with facilitation of those processes in support of sponsors, partners, and the CalHERS project. OSI relies on project sponsors to engage advocates and determine program priorities. Once the priorities are identified, OSI and the CalHERS project work to fit those priorities into IT release schedules based on the capacity of the 6 systems.
Members, you have any questions, specifically with regard to CalHERS? Mr. Stone.
Thank you, Madam Chair. Thank you, Ms. Hayes, for your presentation. I know that the rollout of the program has been a challenge for your agency that has resulted in many backlogs of Medi-Cal applications. And I understand you're dealing with an electronic system that has to communicate with many different counties and agencies. My concern is that this was supposed to be a federally funded program, and due to the backlog and what I'm learning to be manual overrides, that we have to take money from the general fund now to kind of augment the federal programming and implementing this program. And my concern is the backlog of people that need those services. What are you doing to reduce that backlog? Is the electronic system that you're utilizing more effective now than it was a month ago or months ago? And how can we streamline the application process to make sure that the neediest of our citizens in the state of California are getting the care that they richly need?
There's been significant reduction in the backlog, but I want to defer to Department of Healthcare Services to talk about the details of that, but we've been working very diligently with the counties to reduce those backlogs. But part of this process we're talking about in terms of prioritizing change is leading to more efficient processing in the system. So their changes are being prioritized to help reduce those impacts and those manual processes.
Is it fair to say there's still bugs in the system that need to be worked out to eliminate these backlogs, or do you think you're kind of over the hump now and we're getting to more of an automated process?
Some bugs, but I think most of the current changes are related to perfecting the system, making it more efficient and effective for the users and for the public.
Okay. Thank you.
And so Senator Stone, I don't think there's anyone here from DHS that can answer that specific question, but let's put a pin in it.
Okay.
Because it'll come up again at future hearings.
Okay, great.
Okay?
Thank you.
Anything, Senator Monning? I have a couple of questions with regard to kind of whole programs and whole in populations that are entitled to the services who are kind of left out of the initial design of CalHERS. The program formerly known as AIM, former foster youth. Where are you, because we're now 18 months in, where are you in terms of temporary workarounds to meet the needs of those 2 program participants, as well as where are you in terms of the time frame of CalHERS fully being prepared and able to address those 2 programs or those 2 populations?
So again, I'm going to need to defer to Department of Healthcare Services, but those changes are in the queue, and Department of Healthcare Services is working with their stakeholders to ensure the priorities are set for the CalHERS project in terms of implementing those changes.
And so DHCS determines priorities and timeline, and then they inform you, or what role do you play in that at all?
So the way it works is that the program sponsors determine business priorities,
okay,
and we rely on them to have those interactions with their external stakeholders. But once priorities are then identified, the CalHERS project then goes through a process to assess capacity and the ability to implement that change based on the project's capacity, also our our partner systems capacity, the consortia systems plus meds at DHCS. So we have to factor that in. It's kind of a universe of all of the impacted systems, and how do we accommodate and make sure everybody has the capacity to introduce changes together when we need to do them together.
So based on what you do, can you at least tell me if the AIM fix and the former foster youth fix are on your horizon now, or do I still have to go back to DHCS to see where they are in the process?
The AIM, I'm not sure. The former foster youth is one of the changes that are in the queue.
It's currently in the queue?
Yes.
Okay. So since I'm hearing that that's for next February, I'll be asking DHCS what they intend to do between now and then at the appropriate time. LAO or Finance? Nothing? Any public comment on CalHERS?
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, and we very much appreciate you agendizing this item and asking these important questions. We are proud of the achievements that CalHERS has had in terms of enrolling 3 million Californians in coverage. That is wonderful, but we think that the questions the committee has asked about the process are very important. We've really seen that CalHERS has been built behind closed doors, and I just want to be clear that from our perspective, there has not been stakeholder engagement outside of the state program sponsors and the counties. So AB 1296 does require a stakeholder process. That's a requirement on HHS agency as well as DHCS and Covered California. So those meetings have happened, but we've been given sort of little snippets, like here's what's happening, here are little pieces, and it was not until mid-February that we finally got version 11 of the 24-month roadmap. We have grave concerns. DHCS and Covered California have identified that program, making sure people are entered into the right program, get the correct eligibility determination. They say that's their top priority, but as the chairwoman has noted, there are whole programs left out. And to be clear, the former AIM program, now called the Medi-Cal Access Program, is listed as TBD on the roadmap. So it is nowhere there. So we have pregnant women going into more expensive coverage when they could be qualifying for the Medi-Cal Access Program. We also have a concern about notices. I think you all have probably heard from constituents about how confusing the Covered California notices are. The chairwoman's bill of last year, SB 1341, is on the roadmap, but we hope that there will be other changes made to the notices. We have appreciated working with Covered California to clarify some of the languages, but there's still basic misinformation going out to people and a lot of confusion. Lastly, the process that we've had so far on having stakeholder input is that we have a 5-page list of change requests without sufficient definitions. We have asked the department, Covered California, and CalHERS for a list of those definitions. When I see things like 5% disregard or basic income or eligibility, immigration things listed, we have grave concerns that some of those pieces are not yet in the system, but we can't really gauge the seriousness of that until we get those definitions. So any assistance your committee could provide with that, and we look forward to further engagement with the HCS at the next hearing that is relevant.
And thank you very much. And that hearing where this issue will be taken up is scheduled for March 19th.
We will be back.
So the appropriate representatives from DHCS will be there, and we'll have a fuller conversation with the appropriate people at the table. Thank you. Next witness.
Thank you. Jessica Haspel with Children Now. Thank you, Chairwoman Mitchell and members of the committee. We appreciate the attention, especially to the former foster youth population. This is one of our most vulnerable populations. The ACA, when it took effect, it's very clear. Former foster youth who age out of foster care are entitled to coverage up till age 26. This is a provision that is supposed to give them equity to what their peers have had for many years now, which is to stay on a parent's insurance plan. And yet, our systems are not equipped to handle them, and it's a huge problem. Our state system does not have anything programmed in for this population, and while it is on the roadmap, it's on the roadmap for February 2016, more than 2 years after the law will have taken effect. And as a result, those youth that are going to that portal now, over 20% of them are being denied Medi-Cal. They're told, sign up for private insurance, you don't qualify for Medi-Cal. Of those that are getting into Medi-Cal, they're getting into the wrong program. There are some workarounds in place. There have been some measures taken so that if they go to the county, they can potentially get into the right program. But that's not a sufficient workaround, and that's not a reason why it's okay to delay actually changing our system to give them a correct determination. It's not about efficiency for this population. It is about them actually being able to get a correct determination that allows them to access care that the law affords to them. And so I very much appreciate the attention to this issue, and certainly appreciate that it will be part of the upcoming March 19th hearing, and look forward to hopefully seeing both the issue reprioritized, as well as, while there are some workarounds in place, there are additional workarounds that are needed.
Mr. Stone.
Thank you for your testimony. Could you elaborate a little bit more on the foster care issue? Because I was very concerned on the Riverside County Board of Supervisors when I was a member that, after 18 years old, these kids get pushed out and become a part of our criminal justice system instead of investing them in a transition period. And now I'm hearing today that they are entitled to getting health care through Covered California, Medi-Cal until they're at least 26 years old, or if they're still having financial problems, can be in the Medi-Cal system thereafter. What has been the problem in establishing eligibility post 18 years old to get them covered? Where's the problem with the agency?
There's a number of issues. The one, that I've brought to attention today is simply the programming is not there. So
Just structurally within Cal HERES,
yeah.
there's no category that they automatically plug into.
There's a question on the application that says, were you in foster care at age 18 or later? You check yes to that box, but the system doesn't recognize that means anything. So then you have to continue through the full application, provide information that's not relevant to your determination of eligibility. So you have to continue through this application, provide your income and tax information that does not factor in or should not. And you get to the end of the application, and what happens, because the functionality is not there, you either are determined to not qualify for Medi-Cal at all because you don't meet the income requirements for what is programmed in, or you're determined to potentially qualify for Medi-Cal based on your income and put in another program. Certainly, we're happy that some of those youth are winding up in Medi-Cal. Certainly, they have coverage, but there are implications of being in the wrong program, especially as it relates to their retention. This population is eligible for continuous coverage up until age 26. So if they're put in the wrong program, they're getting the wrong redetermination forms and potentially being dropped from coverage on an annual basis instead of retained up to 26. As you've pointed out, this population is really mobile. They've got a lot going on for them, and so it's really critical that they be in the right program, that they be retained, and they be able to access care.
Madam Chair, would it be appropriate for Cal HERS to address this problem and what they're doing to fix it? Thank you.
Thank you.
Go ahead.
I'm sorry, I didn't hear what you said.
Well, and I think the reality is that's why we're going to have California Department of Healthcare Services here March 19th, because as I understand it, they are the drivers in terms of the system design. Cal here does what Healthcare Services tells them to do. So she's the mechanic,
Yeah.
if you will, in terms of you tell me what needs to be fixed, I'll fix it.
Okay.
So it'd be great if public testimony just on a high level, kind of hits on your issues, because we really want to be able to engage in the discussion, and DHCS isn't here.
Okay, when we do have that hearing, are we all going to be sitting at the same table?
We will be here in support of DHCS.
Okay, because I think this is a very important issue that needs to be addressed, and I think we need to have all the principals sitting at the table and solving this problem for our foster youth.
Gotcha.
Thank you.
Yeah, right, I agree.
Carrie Sanders with the California Pan-Ethnic Health Network. And just to reiterate some of the comments, we're a statewide multicultural health advocacy organization. We were one of the original groups at the consumer stakeholder work group of AB 1296 that was tasked with providing input on some of the priorities, the programming priorities in Cal HERS. And so we've been at the table. We've had plenty of discussions, as Elizabeth has mentioned. However, it does feel like it's sometimes one-sided. We have provided detailed recommendations. We've brought up problems to DHCS about things that need to be fixed. And, we only to find that some of these things have continued to go on. And here we are, 1 year into, or, we're in our second year of open enrollment, and foster youth, as well as, women in the Medi-Cal access program are not being properly determined. So, we understand that it's a complicated system. We know that there are a lot of other pressures and decisions, but we really, do urge you through this process to ask those questions about how these priorities are getting made, why these particular populations that are very, very vulnerable are not being prioritized when we talk about programming, and also how, perhaps we can strengthen some of the the stakeholder processes so that it's more of a two-way conversation, and that there are, that we know that some of these priorities are being met. Thank you.
Thank you. Next witness.
Hi, good morning. Tam Ma with Health Access California. We're the statewide healthcare consumer advocacy coalition advocating for quality, affordable healthcare for all Californians. I want to echo the comments of my colleagues from the Western Center on Law and Poverty, Children Now, and CPEN. As consumer advocates, we want to work with the department to make the system work, and we support the staff recommendation to keep this item open and really appreciate the committee's interest and oversight over this issue. Thank you.
Thank you. Next witness.
Thank you, Madam Chair and members. Kathy Senderling with the County Welfare Directors Association. As you know, counties are really proud of the work that we have done to help implement ACA here. More than 3 million people have newly enrolled onto Medi-Cal, and that's great news for all of us. Unfortunately, our workers have had to do that without a fully functioning computer system. Obviously, we don't need to get into a great level of detail. We'll do that more on March 19th, and you've heard a really good, I think, flavor of some of the issues. Apropos to this hearing, I do want to say that we really do appreciate OSI's leadership in taking on the idea of this 24-month roadmap. It really needs to be a living document because 24 months keeps moving, right? We just had a new release over the weekend of changes and fixes to the system. Now we're looking ahead to the next one in July, and we have staff involved right now talking about the details of that. So we really do appreciate CWDA being engaged in those discussions about our priorities. And what we've tried to do is prioritize issues that affect our workers directly and also issues that affect our customers. And the two things are really intertwined. I mean, if our worker is banging her head against a computer screen because it's not working for her, that customer is not going to get accurate and timely service. If the customers can't get the information into the system, our workers can't help them get accurate and timely eligibility determinations. So it's really a two-way street and a balance that we've tried to help strike in the document. I just want to say also finally in closing that it is a long process. I mean, 24 months is not enough to fix all of the issues that are outstanding on the Medi-Cal side or on the Covered California side. So this will of course be an ongoing conversation. We look forward to engaging in that in more detail on March 19th and being available to the committee to ask and answer questions as you see.
Go ahead.
Thank you for your testimony. I appreciate it. Are you in agreement that you being a stakeholder have had very limited interaction with the development of this program and would like to see more interaction?
I think, so I would say that in the early days of the original development of CalHERS, we were not included to a great enough degree to help overcome some of the issues that we now see that we are facing. We have raised that as an issue, and I do feel and thank again OSI, DHCS, and Cover California for including CWDA in more of the conversations. We actually now have two staff who are co-located at the CalHERS project. They came on board in December, so you can see more recently, we really do feel like we have them more included. I think making sure that we're getting the perspectives from all of the stakeholders, for example, on the former foster care issues, on some of the other issues that were raised, is really important to understand how many people is this affecting and making sure that they're being prioritized appropriately in this group. You can't do everything at once, but making sure that folks are not getting put into the wrong program or requiring a lot of manual workarounds, which is what we're really doing a lot of right now at the county level to try to make sure that that foster youth is picked up. Oh, that's a foster youth. They don't need to go through that whole process, trying to help them get on. Some of the other kind of subpopulations that Ms. Landsberg mentioned that aren't yet programmed in, we've been trying to do what we can to make sure they get into appropriate coverage, but it really does involve everybody at the table making sure that those voices are heard, I think.
Thank you.
And I think the result of everyone not being at the table initially has led to a series of legislative proposals that have gone through the process. My bill on lack of specificity with regard to the NOAAs, the notices of action, Ms. Bonilla's bill. And so it's been this kind of push and pull in terms of through the legislative process trying to play catch up to make sure these populations are served. And that's the role we will continue to play in our oversight capacity in this committee March 19th. So DHCS, you should be on notice. Thank you. Next witness.
Thank you.
Hi, good morning, Chair and members. Michelle Cabrera with SEIU California. And I just want to echo much of what Kathy just put forward, which is really clear and comprehensive, and add that in terms of, well, first of all, thank you to the Chair for your leadership on making sure that we get timely and accurate Medi-Cal enrollment. These delays have required manual workarounds from the workers, which has resulted in thousands of hours of overtime, which, you know, our workers have done because they are just as frustrated as the clients at this point. And most importantly, these delays are preventing timely access for people to get into Medi-Cal when they most need it. On the issue of the roadmap, we would like to suggest that there be benchmarks, and we will be back on the 19th to testify on that. And just wanted to add that we think it's important to ensure that the workers are included as part of this stakeholder process, which we hope will unfold as we continue these conversations. Thank you.
Thank you. Next witness. You just got, okay. Got it.
Good morning, Madam Chair and members. Brian Allison on behalf of the American Federation of State, County, and Municipal Employees. We also represent county eligibility workers. We also are in agreement that our workers need to be included in the stakeholder process as well. While there are problems with the system, we recognize that everything can't be fixed. So I'm in agreement with much of what Ms. Cabrera said with SEIU as well. That we want to make sure our workers are included in that process as well. And we look forward on March 19th to be able to talk about those in more detail.
Thank you very much. Next witness.
Aaron Fox from the Los Angeles LGBT Center. Madam Chair and members, thank you. Just wanted to raise one issue. I believe that the committee is likely in receipt of a letter from the California LGBT Health and Human Services Network talking about adding the collection of sexual orientation and gender identity data to the streamlined application in CalHERS. Currently, it is not. And as far as LGBT people not being counted, that means we remain invisible. We still don't know how many LGBT people are in Medi-Cal or how many LGBT people have chosen a covered California plan, and that data is really invaluable to health outcomes. We've had really productive meetings with covered California policy around this. DHCS has indicated that there are budget issues that have caused them from not including optional collection of sexual orientation and gender identity data on the application. And so that's why I wanted to bring it up here today. And so we're happy to work with the committee as you move forward to make sure that our LGBT people in California are counted through this process.
Thank you. LAO Finance. Did I ask you already? Okay, so thank you for responding to the questions from the committee. Clearly, March 19th is going to be an important next step conversation. I'm clear about the role OSI plays in the overall planning and implementation, and hope that OSI will also be present March 19th so we can have a full, complete conversation. Thank you. We're going to move on to Office of the Patient Advocate. Good afternoon.
I think this is on.
Yes, I think it is.
Good morning, everyone. Madam Chair and members, my name is Beth Abbott. I am the new director of the Office of the Patient Advocate, and I want you to know I'm pleased as punch to be there and happy to be able to talk to you about our budget change requests that we have in. We are the organization that you know who has had their charge refocused over the last year. We have had a long time history of being responsible for certain consumer inquiries, and that has changed based on legislation from you all and signed by the governor, so that we have become the public reporting entity. And we are doing that with enthusiasm and, I believe, excellence. We have put in a BCP to convert one employee currently on duty who is a term-limited employee to a permanent position. And the reason that we care so much about this is she is the person who is responsible for our complaint data reporting analysis, which is a very, very important upcoming project for us. We have done, you may be more familiar with our OPA report cards that have been in existence. We're working on the 15th release of that, 15th year of that. The complaint data process in SV 857 is about to be unveiled. We're working fast and furiously on that. And that's why we're asking for the additional money to have that staff remain. We are on target with our complaint data reporting. We are getting complaints from consumers, and the idea is to look at them across 4 state health agencies: the Department of Insurance, the Department of Healthcare Services, Covered California, and the Department of Managed Healthcare. And it is no easy task because everyone has very different data collection mechanisms and reporting requirements built into their own organization. So we're attempting, per the legislation, to put that in a framework that we will be able to look at patterns and trends and ultimately be able to do analysis and make some recommendations regarding where are these complaints coming from, what kind of consumers, what geographic area, what health plan, what type of complaints. Are these complaints in rural California? Are they in Los Angeles? Are they regarding primary care? Are they regarding specialists? So we think it's really a very unusual and excellent project for us to work on. It's the first of several that we are doing, and I think it will set some precedents for other states. And we have gotten our pilot information from the 4 agencies to do a test on this input. We have had a fairly iterative process about how the coding will work, and we're in the process of standardizing all of that. So that is why we are petitioning you for some additional money to support this project that we think is very important.